We have the first two speakers who are going to be debating, and we have Dr. Sripathi Kamath, who is the Associate Professor of the Retina Department at Father Muller Medical College and Netrajyoti Retina Center from Mangalore. And his topic is temporal flap and gas needed for better functional outcome. And contradicting him is Dr. Jatinder Singh, who is going to be telling that the inverted ILM and air is enough. So shall we start the first set of debates, and please stick to your time.
Madam, am I audible?
Yes, you are.
Yeah, okay. My slides are also seen, right?
Yeah.
Good evening, everybody. At the outset, let me thank I Foundation and the Chitra Madam and Ashriya for giving me this opportunity to talk in this particular forum. We are going to discuss, basically, this is a kind of presentation which has helped me over a period of time. Basically, I myself have evolved over different types of macular surgeries, and I have basically doing this particular technique now, and it's holding good for me. So this particular topic wherein I will be talking about is the temporal only flap and gas. Is it enough for the macular hole closure? As we have understood in the various series of talks, predominantly the principle in the management of the macular hole largely exists with relieving the anterior and the posterior, the anteroposterior traction as well as the tangential traction. And the smaller holes generally do not give much of a problem. Wherein the conventional pars-plana vitrectomy, removal of the membrane and the internal limiting membrane, and putting a short tamponade generally was good for most of the smaller holes. Now the problem comes with the medium holes as well as the large sized holes or a recurrent holes. So the medium sized holes, the holes which are about less than about 400 microns, 250 to 400 microns, generally do well with the conventional technique. As against larger holes which are more than 400 microns, wherein we may have to look into some other techniques like an inverted flap or adding a short-term tamponade with an inverted flap. However, the various other techniques, I think this entire talk is on the macular hole. So we are able to see most of the techniques which have been described. So maybe a macular, as Madam was telling about the macular hole hydrodissection, usage of a macular buckle, or various other techniques can be generally sorted for based on the individual practices. So predominantly, when you see the problem comes with the larger holes which have got a poor closure rates. The most commonly resorted technique would be the inverted flap technique. But my problem was whenever I sorted out for this particular kind of a technique, the problem was I was not able to get multiple flaps. Sometimes these flaps used to come off. I may not be able to fold these flaps like what is being described generally. So there was a lot of unpredictability with the multiple flaps. And whenever this ILM, which has been stuffed with the multiple kind of the hole which is stuffed with multiple kind of ILM pores, when you look these particular holes over a period of time, there was a large area of a kind of an RPE atrophy, which was there very much evident in the central part of the macular hole. So that appearance also made us think that should we look for should we actually look for some other technique. So and aggressive ILM peeling itself again caused more of a collateral damage in the initial part. Then maybe subsequently when we made our techniques more this thing, then I think the aggressive peeling was not a problem at all. So I was looking for a technique which has got a single flap because wherein a single flap which is placed over the macular hole generally would it give a better kind of a picture. So therefore I sort of got a study for myself to improvise my technique. So I evaluated my patients wherein I used a single flap to evaluate the efficacy and safety of a limited temporal flap for the internal limit of the internal limit membrane for the macular hole closure. So my patients predominantly underwent, I generally stick to a 23 gauge vitrectomy because of my own reasons, wherein I used the 23 gauge vitrectomy and then I stained with the conventional brilliant blue dye and did a temporal flap. Basically, predominantly, I lifted off one half of the area and just covered that particular area of the macular hole with the temporal flap and used a 0.3 cc of expansile gas of a 14% 0.3 cc gas. I did not dilute the gas for a non-expansile mixture as usually we would do, but I used a 14% non-expansile expansile gas into the eye. And after the fluid are exchanged. Inferior quadrant, couple of patients have had a small breaks wherein I did a laser barrage around that area. And I stick, either the problem was about the post-operative face down positioning. So I gave my patients only of 3 hours of post-operative positioning, face down position. And more importantly, this gas which was injected there was a faster resorption. Therefore, most of the patients I could do the OCT within 1 or 2 weeks of the surgery. So this was the technique wherein I predominantly stained the entire ILM with the brilliant blue and did a limited quadrant temporal peeling and then inverted that entire flap on the fovea. I did not do any kind of papillomacular bundle area flap. I just did a temporal flap and closed the entire area with the temporal flap. So this is the picture you see here in this particular photograph here. So this was the flap. Here it is a superior flap. Then I basically looked into an area wherein either a superior or a temporal flap would do the job. So I had a photograph of the superior flap. This is the area where I have peeled. So this flap curls out and then it just sticks to the area. Okay. So what I noted is this simple temporal flap or the superior flap, whichever it is there, the single flap helps in closure of a macular hole here. The sign what we see here predominantly is a kind of a glistening reflex. The reflex of the ILM,
1 minute left.
ILM touching the macular hole. And this is how the glistening surface would look like. This will tell that there is no fluid between the ILM and the opposed retinal surface. Therefore, this would give a better kind of a picture. So my results in the patients were significantly better. There was a good kind of a macular hole closure. I predominantly stick to short-acting tamponade because I use a single flap. So the flap adherence is better with a small amount of gas tamponade because the better arc of contact and the lesser chances of displacement as against the air. Wherein you use air, then the chances of the flap dislodgement may be there. So therefore, I use a gas as a mixture. And the short-acting also gives an advantage of providing a clear and a better view within 1 or 2 weeks. So you see here, this is a very important picture here. At the end of about 1 week, this was a picture wherein I could see one single flap of an ILM here. This over a period of time, it gives a fantastic closure. This I initially thought that it is a non-closure, which over a period of time nicely closed over about, this is about 4 weeks. I see a beautiful closure of a type 1 type of a closure. Similarly, you see here at the end of 1 week, you have only
Doctor,
a single
time over.
thing which generally closed down. Similar pictures closing down, sir. The concept what I want to bring out is a delayed closure also a thing which is there. So with this kind of a single flap gas, I feel is a must for my technique. I also have certain questions for the panel, whether the retina, does it regenerate? Does the ILM have an ability for a contractile component? And are we just questioning the conventional theory of tangential traction? So with this, I want to conclude that minimal temporal peeling with a short-acting gas tamponade is a must, and gas is required for when we do only a minimal peeling, and will be a safe and effective technique achieving early and better closure. Thank you, sir. Thank you.
On to you, Dr. Jatinder. Nice talk, doctor.
Thank you, ma'am.
So we'll take the questions of Jatinder sir's.
Yes.
Good evening, everyone. Am I audible? Are the slides visible?
Yes. Yes.
Okay, so I'm here to counter what Dr. Sripathi has mentioned. I will be talking in favor of inverted ILM flap with air tamponade. Let me set the arena right. We're talking about idiopathic macular. Pardon?
Make it
full screen, sir. Yeah, it's better.
Yeah.
So setting the arena right, we're talking about idiopathic macular hole, which may be small to large, which are treatment naive, not the persistent or the reopened holes. And in both the cases, we have managed to achieve the surgical endpoint. So let's understand what is mechanism of how does macular holes close. We do an ILM peeling, which induces a titrable trauma to induce a fibrocellular response. The flap, in addition with the tamponade, provides a watertight environment at the hole site, at least in the initial period. And as the time passes, it acts like a scaffold for the retinal gliosis. Flap, in my opinion, they disintegrates over 3 to 6 months time in most cases. This might be because of a tissue remodeling, and air, because of the surface tension in the initial period, holds the flap in its place. So this is the classic description given by Michaelewska. This is the inverted flap technique. We bring the ILM peeled towards the center, but don't peel it over the edge. And the flap is then inverted over the macular hole. This is just a cover. This is no stuffing or plugging the hole, the flap into the hole. There's plenty of literature since it has been published initially. And countering the two is the inverted flap technique, which I'm proposing is we do a 360 peel instead of doing a 180-degree peel. So we achieve a circumferential release of tangential traction. No adjuvants are needed to hold the flap. However, the temporal flap has been proposed as a modification in an attempt to reduce the ILM peeling induced iatrogenic trauma over the nasal side of the macula. The timing of the macular hole has been described that most of the holes close within the first 24 hours. So we really don't need gas. And even if the hole hasn't closed in the first 3 or 4 days, the air bubble has resolved. The macular hole continues to heal by retinal gliosis. So this is in a case example, 1000 micron hole, which had an inverted flap done. It was a large peel, almost 2 disc diameters around the hole. And you can see the whole edge is getting approximated and closing eventually. There is some amount of retinal gliosis purely because of the size of the hole and not because of the flap. The vision improved marginally from 660 to 636. So this has been proposed. There are 3 basic components. One is providing an interface for glial cell proliferation. The other one is to induce the glial cell stimulation. And third is to provide an tamponade at the site. And if you can increase one component of this by providing an interface, you can still achieve a good success rate, which is the composite of all the 3 circles in the Venn diagram. And there have been different publications on this subject. Air has been shown to be equally efficacious as compared to gas for macular hole closure, even without inverted flap technique. So this is one of the patients a patient who had to travel overseas within a week, and with the gas, it would have been impossible. And we achieved a good surgical success. You can see the 10 days post OCT, the hole is closed just with air. So in my opinion, the need for gas is unnecessary. The gas composition related issues are there. There is no fixed percentage which has been described. There can be a lot of errors in composition. The post-operative IOP spikes, especially in phakic and pseudophakic eyes, can be disturbing. The accelerated cataract that we see in phakic eyes will result into quick subsequent surgery. Travel restrictions to even to high altitude is difficult. Posturing difficulties and delayed visual rehabilitation, and in rare situations when we need GA, it might be a problem. So these are the few examples. You can see this feathery cataract, which will remain for longer time because of the gas contact with the lens, and sometimes it can cause a progression of the cataract, rapid progression. This is a patient who developed angle closure glaucoma because of the inadvertent expansion of the gas bubble. So the concerns that are there with the inverted flap are purely baseless, that it requires a lot of skill. You barely need, it's not a very skillful surgery. It's not that time consuming. The ILM flap does not interpret the centripetal shift of the hole because we are not stuffing it. The dye toxicity is minimal, and most of the dyes that we use are pretty safe. So what I propose is doing a minimal ILM peel, no tucking, no plugging, maintains the retinal sensitivity in the unpeeled area. And in the rare setting, if there is persistent hole or a reopened hole, which I am yet to encounter, the residual ILM that we have left within the arcade can still be used as a free flap or a pedicle graft. And there are a lot of publications on this which have shown the good anatomical and functional outcome. So this is the case where you had a hole, and the hole edges are approximated. You can see some hyperreflectivity, but autofluorescence is purely
Doctor,
like
4 minutes left.
Yeah, I'll just finish. So you don't see much of iatrogenic trauma because of the procedure. The post-ILM peeling morphostructural alterations that we see are mostly in the temporal macula, where the temporal peel anyway would be resulting into the similar changes. Most of the function, especially the function, is reversible. The minimal impact on visual function, if at all. The ILM flap contraction has been reported with temporal flap. That's because of the residual ERM over the ILM. The Muller cell proliferation can happen on the undersurface of the ILM. And this is more commonly seen with large flaps and in younger patients. And this will require resurgery because of the worsening of metamorphopsia. So I propose that inverted flap with ILM flap is with air is better than temporal flap with gas. It gives you early rehabilitation, facilitates early assessment of the outcome of the surgery. There is no prohibition for air travel or travel to high altitude. Reduce treatment burden. Avoid elevated
Doctor,
IOP
time over.
complications. Yes. And it avoids the difficulty and errors of constituting non-expansile gas. However, I would wait for a prospective, well-designed, randomized controlled trial, which will assess the outcome on a long-term basis with all these tools. And all this, the hypothesis that it gives you less trauma is countered by the greater chances of ILM unfolding and ILM flap contraction. To summarize, air tamponade with non-supine positioning is adequate when inverted flap technique is employed. Thank you all.
Sir, excellent talk. So basically, Dr. Sripathi told we should not treat ILM as a vestigial organ and peel it indiscriminately. And do you think inverted flap technique has any prescribed, like the macular skull told 2 disc diameters? Is it there is a calculation for it, or 2 disc diameters is standard thing for?
And for large holes, I do a 2 disc diameter size around the hole. But for smaller holes, my basic criteria is to peel 1.5 hole width of ILM around the foveal hole.
And
The larger the hole, the larger the peel. I mean, they're just directly proportional.
So my question, Ashray, my question for the panel is like, see, in my OCT, whichever I showed, there was a small kind of a flap of an ILM, which was there, which is over the macular hole. Now, how do we explain that this flap of the ILM helps in the closure of the macular hole subsequently? Like, how does that happen? If you see, if I share my, it is just like a one small flap which is there.
Yeah.
Yeah.
Can I answer this one?
Yeah, please.
Yeah, so actually, basically, if you remember the basics of pathology and all, any wound closure requires a closed environment. Okay, so as long as the ILM flap, as you rightly shown in your figure, it's creating a closed environment, it can induce a better glial proliferation. Okay, so that is what is inducing the glial proliferation and bringing the lips closer, and which is resulting in a hole closure. So if you observe in your OCT, the bottom left, it's a nicely closed. So it just follows any principle of wound healing. It basically it requires a closed environment. You are right. If the ILM flap is intact, covering the hole, it definitely promotes hole closure. In fact, there is a functional adaptive imaging studies which have been presented in the recent RO, which also suggests the role of calcium transmission. Once you peel the ILM, the vision improves not only because of the hole closure or the approximation of the edges, the calcium transmission also improves. That's what the recent functional adaptive OCT image has shown. Yes. Hope I'm able to answer your question.
Yes, yes.
Dr. Sripathi, you said I need a short-acting tamponade. Dr. Jatinder Singh is already using air. Why are you not using SF6? Why are you using C3 effect?
It is just the availability of the stock, because to maintain the two kind of a stock, I use C3 effect for other procedures also. Okay. So it's meant to maintain one single stock. I think the point, like what sir was saying, like the risk for angle closure glaucomas, the need for flight travel and things like that. I think with the 0.3 cc expansile gas, the chamber of the eye which is being filled with the gas is for a very short duration. So earlier when you used to fill the entire eye, I think sir may answer this. When we used to fill the entire eye with the non-expansile mixture of C3F8, that's when we used to have a larger areas of instances of angle closure glaucoma and inability for the patient to travel, inability to get a good image of the fundus in the initial postoperative period and things like that. But when I switched over to a 0.3 cc gas of an expansile mixture, so the entire thing, and it gives a good, in an erect posture, it just gives a good view of the fundus as well, and the chances for glaucoma also is much lesser. And with the one single flap, to maintain that flap, I need a little longer duration of contact. Maybe air I felt was a little too short for an absorption when we keep one single flap as against the sir when used to do a 360-degree peel.
Sir, but in vitrectomized eye, even if it quadruples, 0.3 cc will be 1.2, and the arc of contact, which only 3 hours of prone positioning you are giving. So, does really this tamponade is making a difference to the patient, or you could have as well used air and spare even that 0.3 cc of usage?
No, Ashray, this is not just one bubble. This is eye filled with air in which
Air
he's injecting C3F8. So now it gets diluted to be about 12-13%, if I'm not mistaken, about 10 to 12%. I think.
Yeah.
Yes. So good, with lot of food for
I
thought.
agree with Ashray also what you're telling. If I have to add, if it has to close, it will close within a week.
Yes.
So
Barbara, ma'am?
whether it's air or gas, if it crosses that duration, then it's a different ball game. So sometimes you have seen when you had an intraoperative OCT during FAE, intraoperatively also the hole starts approximating this thing. And most of the time, the next day post-op itself will be whole size, will be almost very small if it has to close. So,
but that is not the case that if a hole doesn't close, it will never close. That is not the case. It is very.
You are about to...
I have some questions for you. It's very interesting discussion. I find out that whatever shape and whatever size of flap we are using, I think if the flap goes inside the hole and gets stuck, it prevents the real closure. And at that point, the visual acuity does not increase. So I would like to know what you try to avoid, what technique, if you have a technique, what do you try in order to avoid that the flap sticks inside and prevents the real closure? Do you have any tip? Because I have tried different sizes, different shapes. I thought if it was larger, it would stay on top, but then no, it's not true. I have seen large flap going inside. I've seen small flaps going inside. So I don't know. What do you think about this?
I think for that, what Dr. Sripathi has displayed. Yeah.
I also, sorry, I would like to tell you that in order to avoid that, what I have been trying to do is, before creating a flap, mobilizing the edges of the hole very gently with the Thanos scraper, but it's a very risky in order to avoid damage on top. Anyhow, I'm trying to mobilize and shrink and get the hole smaller in order to keep the ILF flap on top. And I do so before creating the flap. So what did you do?
Ma'am, in your hands, maybe that mobilizing the retina might work, but in hands of mortals like us, I think it is going to cause more trauma. What I basically do is ensure a very completely dry retina with complete fluid air exchange and absolutely no fluid. And at the end of the procedure, using any soft tip instrument, I use the infusion cannula, the soft tip extrusion cannula, with my finger plugging the hole so that there is no passive extrusion, and just roll the cannula tip and reposit the flap over the macular hole. I make absolutely no attempt to go towards the edge of the retina or touch the bare retina as much as I can, and it has worked for me for last 12 years, and I hope others can also.
So you mean you never had the flap inside?
It just barely gets into the inner retina, but it never crosses the, I would say, the inner 80% of the retina. So the most of the hole which repair happens even in natural history, they've shown that the first thing that comes into contact is the outer nuclear layer and then the ellipsoid zone. It doesn't reach that deep. In my cases, I've not seen.
So I've also been doing a similar technique, and I don't see that it causes a problem in closure. So I think I do the similar procedure. I think keeping a slightly larger
Yeah.
flap and keeping it on it, I think is fine. That
Yeah,
we just
I think so.
experiment.
What ma'am is telling, the going inside, it happens in case of macular hole associated RD, which I'm going to show in my presentation. If there is a subretinal fluid, when you do it, then it can go really deep, and it really, comes in between the ellipsoid zone joining from the other side, which might this thing.
Now, telling the truth, even if it does not touch the RPE and the photoreceptors are continuous and the outer retina is continuous, if the flap goes 80% inside, the amount of visual acuity restoration is limited. And I found that because in one case, the patient developed cataract. So with that excuse, I went to cataract surgery and I told her I will do one more maneuver on the macula to try a better closure. I went inside, I tried to displace the flap better. During the fluid exchange, I removed the flap inadvertently and the hole closed perfectly, like it seems never open. And it made me think a lot that in the first maneuver, I made the hole smaller, and then removing the cap of ILM, I made the hole like you've never been there. So
that is one reason why in small holes, I think it's better to remove the ILM rather than having an inverted flap, because then you have no possibility of it going down inside.
It's true. It's true.
Just wanted to take Dr. Hepp's opinion we are using so many techniques. Using one technique should do the job, or should we customize the different techniques? Dr. Hepp?
Well, usually when there is more than one technique to solve the same thing, that means that we don't have an ideal solution, that we're all trying. Some techniques works in some hands, it doesn't work with others, but that doesn't mean it's bad or whatever. Everybody has his own experience, but having more than one option means that we really don't have one standardized technique that we can all agree upon.
Yeah. I totally agree. It's like retinal detachment. If you look at your surgery, all your patients, the worst are always retinal detachment and macular hole. You never know what happens the day after, almost.
I mean, I agree with Barbara and Dr. Elreis. I think the important thing is whatever you do, whether you do a temporal flap, whether you do a multi-layer flap, or you just do a regular inverse flap, don't stuff it inside. I think that's really the thing. Otherwise, rest all of them seem to work. So depending on what's more convenient for you, what works best for you, I think you just choose the technique. All of them seem to work, as Dr. Elreis put.
Yeah, I think the most important thing is keeping the fluid away from the central hole until it dries up. So theoretically, when we just used to put a gas bubble, a really good gas bubble with good positioning, the hole used to close, especially when you increase retinal elasticity by just removing the ILM. So closing the hole by any tamponade or whatever we put over the hole brings this chance of hole closure. The bad thing is now, the more the things that we'll be using over the holes, it's not just the matter that it might prevent hole closure if it goes inside, but it actually stays like this forever. So we'll have, I think the next debate will be what type to put over the hole. So again, though they help in closing the hole, but we ask ourselves, what are they going to do if they stay over the retinal surface, whether it's amniotic membrane or retinal transplant or whatever.